Thanks very much. That was a really great sort of set of context and sort of very helpful for us as pathologists to hear this. I have a few questions in the from the attendees. Actually, this one is I think a very clinically relevant question, which I don't think we could really answer as pathologists. Can steatosis itself cause elevated LFTs without any steatohepatitis?
Yes, the answer is we do see that. There are times that a pure steatosis can do that. So the answer is yes. Although I'm guessing that more and more we're seeing patients. The challenge is we're seeing lots of patients with normal LFTs who are found to have on imaging fat, and those are tougher patients to know what to do with. But the ones we're sometimes pleasantly surprised that elevated LFT patients do just have steatosis. Yeah.
Great, thank you. And actually, another question which I actually saw earlier, which I don't think we got to, which Angela, you might be the best person to talk about this. Someone asked about an area that we didn't necessarily kind of cover in detail, but what would be the related to either hepatitis or other features? What would be the findings in alpha-1 antitrypsin deficiency, and can that be a confounder?
Yeah, sure. So alpha-1 antitrypsin deficiency, classically, we will talk about those pink eosinophilic globules of accumulation that you see in the periportal hepatocytes. That's typically where it starts. I think when you talk about alpha-1 antitrypsin deficiency, I think we do have to keep in mind that we're really mostly talking about the homozygous PiZZ manifestation of it, because most heterozygotes will not generally have a lot of histologic findings that we typically will see. We might see a couple kind of globules, but really nothing of any significance. I think aside from that, I have heard of alpha-1 antitrypsin disease having some sort of manifestation with biliary type issues and a mild manifestation. So I think that's something to keep in mind. But I think personally, I haven't really had a lot of experience with alpha-1 antitrypsin deficiency causing any kind of real hepatitic, like an acute inflammatory hepatitis. I think it's more kind of like a background chronic change that eventually can progress to even a cryptogenic cirrhosis. That's my understanding of it.
Yeah, I completely agree. I think for adult patients with alpha-1 antitrypsin deficiency, they have a quite non-specific biliary findings on liver biopsy, and also non-specific portal inflammation as well. For kids, especially newborn, I think is a very important pitfall to know is alpha-1 antitrypsin deficiency can mimic biliary atresia. So that's a very important differential diagnosis to keep in your mind. And also just in general, people with alpha-1 antitrypsin deficiency, if they have additional another liver disease, their disease fibrosis progress seems to be very much accelerated.
Mm-hmm. Great, thank you both. And I guess one final question I see, which I think Lei, maybe you could take this one, because I know you talked about this, and you addressed it to some degree, but maybe you could come back to how you score iron deposition, and kind of what system do you use to evaluate and grade that? Because as you said, there are a few different ways to do it.
That's a great question. The reason I kind of hand waving, like didn't really go into detail about iron grading, is there are a few different systems, and I invited people to write reviews on this topic, and they all come back saying they don't really have a consensus on which system to use. For me personally, most of the time I eyeball the iron deposition. If this is wall-to-wall iron deposits in every single hepatocyte, that will be grade 4. If there's only periportal distribution, that would be grade 1. And then anything in between will be grade 2 to 3. But a lot of my colleagues also use the scoring system I showed in the talk, in the slide, that you can, depending on what resolution, like at what power you see the iron granules, and then you grade based on that. But I found those two, my eyeballing system and that system described in the talk, overlap quite a bit. So you often end up around the same score.
Great. All right. Well, I think that's all the questions so far. So I want to thank all the presenters this morning. It was really a terrific session. So we will take a short break and reconvene at 10 o'clock.